Hi everyone, today's topic of discussion is bicuspid aortic wall. Coming to the epidemiology, congenital bicuspid aortic wall is present approximately in 1 to 2% of the population, and the male to female ratio is 3:1, and hence it's male predominant. And the prevalence of bicuspid aortic wall and first degree relatives of individuals with the bicuspid aortic wall is approximately 9%. Around 50 to 75% of patients with coarctation of aorta have a bicuspid aortic wall. And it's also prevalent in other syndromes like Turner syndrome, 30% of cases. And the mode of inheritance of this bicuspid aortic wall is usually autosomal dominant. But around 30% of cases of Williams syndrome and ventricular septal defect are also associated with it. Because of the prevalence of this bicuspid aortic wall in Turner syndrome, which is usually X-linked disease, there is a still debate that this bicuspid aortic wall might also have an X-linked inheritance, which is not yet completely proved. Coming to the pathophysiology, normal aortic wall consists of three leaflets, that is the right coronary cusp, the left coronary cusp, and the non-coronary cusp. And see, this is a normal tricuspid aortic wall, this being the right coronary cusp, the left coronary cusp, and this is the non-coronary cusp. And this is because of the fusion of the two cusps, leaving a remnant, which is usually known as the raphe. And this is completely considered as a single cusp, and this is the two cusp, hence this is known as a bicuspid aortic wall. The most prevalent anatomy for the bicuspid aortic wall is two cusps consistent with congenital fusion of the right and left coronary cusp seen in 70 to 80% of patients. An anterior-posterior orientation with the fusion of right and non-coronary cusp is less common, seen in approximately 20 to 30% of the patients. The fusion of the left and the non-coronary cusp is rarely seen. Basically, the bicuspid aortic wall was divided into three types, that is type 1, 2, and also 3. And these are again further divided into A and also B. These are further categorized into A and B on the presence or absence of raphe. All that A category of type 1, 2, 3 have the raphe, and absence of raphe are being kept under type B. Coming to type A, this is type A. This remnant, which is left after the fusion of two coronary cusps, is known as the raphe, which is seen in all this or type A lesions, and this absence of the raphe are seen in type B lesions. Coming to type 1A, which is the most common, this is formed by fusion of the right coronary and the left coronary cusp with a raphe seen in type 1A, which is around 53% of population. In type 1B, which is also seen in fusion of right coronary and the left coronary, and the raphe is usually absent, seen in 19% of the population. And type 2A, which is formed by the fusion of the right coronary and the non-coronary cusp, which is seen in around 11% of population with raphe predominant, that's under type 2A. And fusion of right coronary with non-coronary with the absence of raphe is type 2B, which is 6% prevalence. Coming to type 3A, which is the least common, that's formed by the fusion of the left coronary with the non-coronary cusp. And the raphe, if it's present, it's type 3 with 6% of prevalence, and the absence of raphe, it's type 3B with 5% of prevalence. And this is a normal bicuspid aortic wall. The natural history of bicuspid aortic wall. It ranges from a severe aortic stenosis in childhood to long-lasting asymptomatic disease into the elderly years. Aortic stenosis is the most common complication and may require surgery, most often necessary in middle age. Only 15% of patients with bicuspid aortic wall will have a normal function in the fifth decade. Aortic regurgitation also occurs due to abnormality and may result with or without aortic stenosis. Various etiologies have been suggested to explain the mechanism of aortic regurgitation in bicuspid aortic wall, including the cusp prolapse, the endocarditis, dilated aortic root, and myxoid degeneration of the aortic wall. Endocarditis is more common in bicuspid aortic wall than in normal tricuspid aortic wall. The incidence is estimated to be less than 2% in different series, but the outcome of endocarditis tends to be worse than in normal walls. And iotopathy, that is the dilatation of the ascending root or the aortic root, is commonly seen in association with bicuspid aortic walls with or without significant stenosis. And this is an anatomy of an aortic wall, and this is the sinuses of Valsalva, the sinotubular junction, and the ascending root. And in patients with bicuspid aortic wall, this root dilatation is the most common, which is later followed by the dilatation of the ascending root aorta. The ascending aorta is dilated in approximately 50% of patients and young adults adult patients with bicuspid aortic wall, while the aortic root is dilated in 22% of this population. Moderate or severe dilatation of the ascending aorta or the aortic root is present in 15 and 5% of patients respectively. The risk of aortic dissection in patients with bicuspid aortic valve is 5 to 9 times higher than in general population, but the absolute risk is still quite low. And coming to the treatment, since most of the natural history of this bicuspid aortic wall lands in aortic stenosis in and around fourth decade, and the patient presents to us with signs and symptoms of aortic stenosis. Whenever we have an abnormal aortic wall with reduced systolic opening and the symptoms of that due to AS, we'll see if it's severe AS stage 1 is set when the Vmax is more than or equal to 4 meter per second or the delta P mean more than 40 mm of Hg. Then aortic wall replacement SAVR or TAVI is being considered. If the symptoms are due to AS and if the Vmax is less than 4 meter per second and aortic wall radius less than 1 centimeter square and if the EF is less than 50%, then it's considered severe AS stage D2 and the DSE Vmax, it's more than 4 meter per second at any flow rate, then aortic wall replacement is suggested. And if the if the EF is around more than 50% or equal to 50, then it's considered as severe AS stage D3. Then aortic wall area, if it's less than 0.6 centimeter square per meter square, and the stroke volume index, if it's less than 35 ml per meter square, AS is most likely cause of the symptoms. Then also we consider aortic wall replacement. If there are no AS symptoms, then AS stage C, that is Vmax more than 4 meter per second, and if the EF is less than 50%, then we go for aortic wall replacement, and which is class 1 recommendations. And if it's any other cardiac surgery is done as concomitant, then AVR is done as class 1 recommendations. And if the patient has ASTC with decreased BP or exercise capacity, then surgical aortic wall replacement is done as class 2 by recommendation. Or in patients with Vmax more than 5 meter per second, or if the vein natriuretic peptide is more than 3 times the normal, or if the rapid disease progression with low surgical risk, then also surgical aortic wall replacement is done, that is class 2 by recommendations. And in patients with ASTC, but if the left ventricular ejection fraction is reduced from 60%, reduced from 60% on 3 serial studies, and surgical aortic wall replacement is a class 2B recommendation in patients with AS stage B, which is Vmax of 3 to 3.9 meter per second. And further concomitant cardiac surgery is being done, then surgical aortic wall replacement can be done according to class 2B recommendations. Thank you.